Okay, the recording has started, so over to you whenever you want to begin. Thank you, Dr. Shannon.
Okay, excellent. Thank you everybody for joining us this afternoon. Thanks, Michelle, for putting this together through UAE ABA and ECAE. It is such a delight for me to be able to spend the next hour talking about Assent and specifically on amplifying children's voices towards a better understanding of Assent. My name is Shannon Ward. I'm the clinical director at the Mohamed bin Rashid Center for Special Education, operated by the New England Center for Children. And on the next two slides, I'm going to introduce my team because although I get to be the one here talking about Assent this afternoon and sharing some of the cool research that we're working on, I am just one member of a really incredible team. Please jump in with questions. If you have comments or reflections, please add those to the chat. Michelle is going to help monitor the chat because I will have a really hard time multitasking if I'm trying to eloquently talk to you about Assent and also monitor the chat. But please, I would love for people to jump in and ask as we go on. There we go. Okay, so I am here and I get to talk about a 3-year research grant that we are a part of that is being funded by the Abu Dhabi Early Childhood Authority. And across these 3 years, our research team is going to be looking at Assent practices in early childhood. And as part of this, we have 9 different research projects, 9 different research studies that we'll be conducting across the 3-year span, looking at Assent, what is known about Assent, what are the best ways of doing it, and really trying to help influence and inform local policy on best practice for seeking Assent with young children, but also to have a global impact. A lot of people are talking about Assent right now. There's a lot of really important work, and we're excited to be a team that's kind of investigating this empirically, but from here in Abu Dhabi. This conversation on Assent, I'm going to be talking a lot about Assent as it pertains to early childhood, but I also, I'm not sure the ages of populations that everybody is working with, but truly the essence of Assent really is not solely applied to young children. We're going to talk about people of determination. We're going to be looking at all different kinds of age groups, but a lot of my conversation is going to be towards early childhood. And last, just a moment to celebrate and introduce our research team. So our principal investigator is Dr. Sarah C. Mead Jaspers. She is an assistant professor at the Emirates College for Advanced Education, and she is really spearheading this 3-year grant project that we are a part of. Dr. Michelle Kelly is a co-investigator on this grant, as well as myself. And then our research team, Shaza, who has joined us today, is one of our research associates. Dr. Ida Tarifa Rodriguez is a newly added member to our research team. We have Victoria Nugan, who's a research associate. Reem Shabata is our research executive assistant. She makes sure we get all of our paperwork in on time and just make sure that we are meeting the goals and outputs that we aim to. And then Dr. Javier Vieras Ortega is our research director, and he is helping oversee all of the work that we are doing. So over the next hour, I kind of have this presentation broken into 2 different kind of sections. The first part is going to be really the basics of Assent. What is Assent? Why is it important? Who seeks Assent? Who provides Assent? How do we go about doing it? And then the second part of the presentation is I'm going to share some of the current research that our group has recently conducted. So before we start, I kind of want to pose some questions to the group. And the first one being, we have people from all over the globe, which means that there are people at all different points in their day. I'm assuming some people might have woken up recently. Some of us have been awake all day. But what choices have you already made today? And if you want to put just a couple in the chat, great. Tara skipped the gym to come to this workshop, and she really goes to the gym. She does Orange Theory, I think. Excellent. Wonderful. You know, regardless what to eat, what to wear, chose to attend this webinar, as simple as how you're going to prepare your morning coffee. We get to make a lot of choices. Will you drink an espresso? Will you drink an Americano? Do you want a latte? Do you want to make your coffee at home? Do you want to have it out in public or order from a cafe? I got a Starbucks before this presentation. We, regardless, as adults, have opportunities to make choices all day long. And that is a right that we have, is to be able to make choices. My second question that I'd like to pose is, how do we help children make choices? And the first part of that is by allowing, you know, one way that we teach children to make choices is simply allowing them to do it. We've got to give lots of opportunities for children to make choices so that they can become good at it. We learn from our bad choices. We learn from the choices that don't serve us in the past. So the second question that I'd like to pose is, what are some choices that you provide to the children that you work with or the people that you support? Or maybe what kind of choices do you provide your own children each day? Great, allowing them the choice to choose between items and activities. What order of programs? Do you want to do this thing first, or do you want to do this other thing? What color socks to wear? That's important. Those are important decisions. So, you know, one thing to think about, and especially I would imagine for most people in this chat, the people that we're working with, the clients that we're serving, and even if you're not working in a clinical setting, how many choices are provided across the day? And then beyond that, how do the children that you support, or your own children, or children that you're doing research with, how do they show you that they want to do something? And also, how do they show you they don't want to do something? So you don't need to answer these questions in the chat, but I want you to reflect on them as we move forward. So let's start with what. What is Assent? And to best understand Assent, it's important to know the difference between consent and assent. Oh, sorry. So consent is a formal agreement with legal implications to participate in an activity. And so parents are usually going to provide consent for their child to participate in something. Examples of this might be medical, so if it comes to them getting a vaccine, educational research, signing up for sports and leisure, signing up for a sports camp. When parents sign a permission form for an activity, they are giving consent for their child to participate. Assent is a proxy to consent for those who cannot legally consent. So this is going to be people that are under the age of 18, and especially under the age of 8, and it's going to include some people of determination. Generally, an affirmative response is taken to indicate a willingness to participate in the activity. And an example of this might be when a doctor asks a child if they can take a blood sample. What the doctor is doing is they're asking for assent in that moment. So there are lots of different definitions on assent. And there's a paper recently published by Brox and Smith, and they looked at different definitions of assent that are reported in literature. And I won't read off all of these, but I'll read a couple. So one example is a definition of assent is meant to be an explicit affirmative agreement to participate and not merely an absence of objection. Another definition of assent is to agree to something freely and with understanding. Giving assent is coming to a task willingly, participating in learning interactions without coercion. Children's active agreement to participate voluntarily. So these are all definitions that have been found in published literature. And our Code of Ethics also defines assent, and they define assent, and this is actually one of those definitions on that table. But assent is defined by our Code of Ethics as vocal or non-vocal verbal behavior that can be taken to indicate a willingness to participate in research or behavioral services by individuals who cannot provide informed consent. Assent may be required by a research review committee or a service organization, and in those instances, those entities are going to provide the parameters for assessing assent. So how does this look in practice? So an adult in charge, so this could be a researcher, this could be a doctor, it could be a teacher or a camp counselor. The adult in charge would identify that an activity is going to involve a child's participation. The adult in charge would then obtain consent. Permission from the child's parents would be that that child has their parents' permission to participate. The adult in charge then would seek assent from the child to confirm the child's willingness to participate, and then the adult in charge would initiate the activity with the child. So why is assent important? Why might we care? Why should we care? First and foremost, it ensures that we're operating within a human rights framework and that we're treating all individuals with dignity and respect. The Convention of the Rights of the Child mandates that children are given the same rights as adults. So this would include opportunities to make decisions and share their preferences, that children are entitled to make decisions about things that directly affect them. It's kind of saying, I respect that you have an opinion and I'll allow you an opportunity to voice that opinion. It's also important for behavior analysts because our ethics codes mandates us to recognize and acknowledge its importance. When it comes to obtaining informed consent, our ethics code states that behavior analysts are responsible for knowing the conditions under which they should obtain consent, and behavior analysts are responsible for obtaining assent from clients when applicable. Also, when we're doing research, behavior analysts are responsible for obtaining informed consent and assent when relevant from potential participants when conducting research. Behavior analysts are responsible for obtaining consent and assent under the conditions set forth by research review committees. And what this also implies is that we've got to know the organizations that we're working with. We've got to know kind of the local regulations. If we have different government entities, we've got to know what their expectations are about assent. And of course, it's important for us to follow our ethical codes. I think it's important to consider international guidance. I think the United Nations is typically a good one. Their advice is usually good. And of course, we need to be thinking about international and local laws and regulations and adhere to those. But I think assent is probably most important when we consider what are we teaching when we ask for assent. And so I'll give maybe just a minute or two if people want to jump in before I give some reasons why I think what I think we're teaching. But what do we teach when we seek assent? Right, self-advocacy. What else do we teach when we're seeking assent? That they have the right to choose. Excellent, Amina. Choice making. That their decisions are valuable. How important is it for individuals to think that my say-so is valuable? Great. I'll jump in on a few. I think we're teaching individuals about autonomy. We're teaching them that I have the right to make choices. I have the right to make choices about my time, about my body, about my things. We're certainly teaching choice making. You can't learn how to make choices if you're not given opportunities to make them. And by seeking assent, we're providing a really safe and controlled way for children to make a choice. I think we're teaching things like negotiation. Can I do it a little bit later? Can I do it with different materials? Can I do this activity somewhere else? All of these are things that we're teaching when we seek assent. And I think the takeaway, a takeaway, is that by treating people with respect and dignity, it means that we're giving people, and that's all people of all abilities, all ages, that they have a level of control over what they experience. And assent allows us a way to do that. And when it comes to conducting research or clinical practice, assent is important because it can protect the child as well as the adult in charge. And this is especially the case when assent is formalized and documented. I think assent is important because it also can provide, it can promote buy-in for activities. If children have agreed to participate, they may be more likely to engage and fully buy into the activity that you've asked them to do. As just mentioned on that previous slide, assent can amplify children's voices within their environment while also building trusting relationships with the adults that they're interacting with. And lastly, I think it teaches important self-advocacy, choice-making, and boundary-setting skills in a safe and controlled manner. So who is it that gives or withdraws assent? So individuals under the age of 18, as well as some people of determination if they rely on caregivers or parents to make legal decisions for them. And when it comes to who seeks assent, this is going to be the adult in charge. So this might be a researcher, it might be a teacher, it might be a parent or caregiver. It could be a clinician at a feeding clinic or a camp counselor, a swimming instructor. Those asking about assent, those are the ones that are seeking it. And when is it that we seek consent? Or another question might be, how often do we seek assent? When it comes to conducting research, we might seek assent at the start of the research project. So this would be at the same time that a consent is collected. We might seek assent at the start of every research session. We also might seek assent continuously, so monitoring for assent throughout the entire research session. For educational context, we might seek assent with different classroom activities. I like to think of a kindergarten classroom or a preschool classroom that has centers, and maybe there's a dramatic play center, and there might be an arts and crafts center or a reading corner. And by children electing where they want to choose their time, they're kind of giving assent to participate in that activity. I am choosing to go sit at the arts and crafts and I'm engaging in those activities. That might be one way that assent is sought or looked after. It also might be during specific activities. For therapeutic or clinical context, we might seek assent at the start of the therapeutic session. So if you had a student coming into or a client coming into your session, you might say, hey, we're going to go over here and we're going to work on, X program. You willing to do this with me? Would you like to come over and do this activity? People also might collect assent throughout that session. And now how? So what are the ways in which we can seek assent? So the first might be just through a verbal question and a response. So we can simply ask children, ask the individuals that we're working with, would you like to be doing this? If they have vocal verbal language and they can comprehend the question and respond back to you, that is one way that we could seek assent. We also could provide a written form. And a written form would be written at the age appropriate level. It would remove all of the jargon. It would be written in a developmentally appropriate way for that client or close to a developmentally appropriate way. And that would kind of be a form that the child or the student could sign off on. Forms might use pictures. There might be a smiley face and a frown face, maybe a thumb up and a thumb down. And I include this example from Docket et al. 2012, just because I think it's super cute. But here is Emily, and she is not agreeing to participate in that activity. So she has a nice bold coloring of the I do not approve. We can also offer choices as a way to seek assent. And so we might provide a couple of different options and simply let the individual choose. by choosing, they're making a choice, and that would give us an indication on whether or not they assent. It could be, do you want to do A or do you want to do B? If they have the language skills to comprehend that question and answer, that is one option. We also can set up the environment with clear options of activities and then let the individual select where they want to spend their time. So we might have a research space that has a beanbag, books, and preferred toys on one side of the room, and then we might have a table with educational activities or that research activity at the table. And we simply make it very clear by the way that the environment is set up, you have a choice. You can hang out over here, you can hang out over here. We can let people vote with their feet. So again, using that center, if children or those individuals are walking over to the reading center, they're going into dramatic play and putting on all the costumes, they're voting, they're saying, this is how I choose to spend my time right now. By letting people vote with their feet, and I think this is especially important with individuals that are nonverbal or not as able to communicate as easily, we can arrange the workspace or arrange the environment so that it's clear that the individual can leave. So one of the things that we talk a lot about in our research team is arranging environments so that if a child is sitting at a table and doing educational activities or is doing research, you want to think about not positioning that child at the corner of a table where an adult is blocking them in, because that kind of gives the impression that if you want to leave, you can't, or that leaving isn't even an option. So we can arrange our workspace to make it clear that if you choose to stand up and walk away, that's perfectly fine. We can also leave doors open in our research context, in our therapeutic and clinical context, as another way to say the door is open. You don't have to stay in this research room. You don't have to stay right here. You can leave and make that clear. So I'll share just a couple of examples, and I won't go through these very thoroughly, but here's a couple examples of researchers offering choice within a research context. This first one is a publication by Rajaram and colleagues, and this was published in 2022. And they were looking at a treatment model that they're calling the enhanced choice model. And so what these researchers were doing is they were doing assessment and treatment of problem behavior for 5 participants. These participants were aged between 4 to 9 years old. They all had a diagnosis of either autism, ADHD, or emotional disturbance. And all of these participants engage in different forms of challenging behavior. So some engaged in self-injurious behavior, some engaged in destructive behavior or aggression. And all of these participants had a functional analysis where the authors identified the controlling variables for their challenging behavior. And then they moved into treatment where they were, their treatment was teaching the participants how to, a functional communication response to access the reinforcers that maintained their problem behavior. They also were teaching those participants to cooperate with the evocative context that were shown to evoke problem behavior. So if a child was engaging in challenging behavior to get out of adult instruction, they were teaching those students how to ask for a break politely, but also how to cooperate with some of those adult tasks. And throughout all of their research sessions, all of their clients or participants had options. They could choose to practice. That's where they were practicing functional communication training or cooperation with the tough stuff. They could choose to hang out. And if they chose to hang out, they could have all of their reinforcers that were shown to maintain problem behavior for free. And those were free non-contingently. And they also could choose to simply leave the research context altogether. So if they wanted to return to class, they could return to class. If they wanted to go home, if it was a clinical context, that might have been an option. So what these authors were able to do is they were able to reduce the problem behavior for all participants and teach those skills that they were looking to teach. But the 2 figures that I shared show the allocation of the times that the participants were choosing to practice, choosing to hang out with their reinforcers freely, or if they terminated sessions. And what you'll see about this graph is that all of the participants chose to practice the majority of the time. Sometimes they said, I really need to hang out, and a couple times they said, I'm done for the day, but they were able to meet the objectives for why they were in that research study, even while having the choice. And here's one more example. This is from Gover and colleagues, 2023. And they were looking at assessment and treatment of food selectivity. So these were children aged 4 to 6 who had selective eating and also engaged in challenging behavior when they were asked to try new foods or consume new foods. And in the context of their treatment options, their participants were given different choices. So they could choose which non-preferred food they wanted to practice with. They were able to choose what they wanted to do with it. So did they want to just look at the food on the plate, or did they want to touch it to their nose or put it in their mouth and start to chew it? So they had those options. And they also could opt in or out of session. Similar to Rajaraman and colleagues, even by giving all of this choice to their research participants, they were able to have consumption of non-preferred foods increase across all participants, and treatment was eventually extended to caregivers. Okay, so switching gears, another way that we can seek assent is by observing for indices of happiness. And so questions that we might look at is the individual smiling? Are they engaged with the activity? Do they look like they want to be doing the thing the adult in charge is asking them to do? Those are kind of, by looking at their body language, by looking at indicators of happiness, we might be able to infer assent with the activity. By contrast, we could also look for indices of unhappiness. Is the individual crying? Are they upset? Do they look uncomfortable? Do they look like they're trying to get away from the activity or escape that research context or that therapeutic context? Those might all be ways to monitor for indices of unhappiness. Just as a matter of time, I'll just briefly go over this, but really this is an example from Mayne et al. 2022 that we're looking at indicators of happiness and indicators of unhappiness for 9 different children. And so they had the participants' classroom teacher kind of monitor and observe and come up with what they thought were indicators of happiness for these different participants, and then indicators of unhappiness. And then they validated whether or not they saw happy indicators during happy conditions and indicators of unhappiness in these kind of non-preferred contexts. So regardless of the skills of the individuals that we're working with, regardless of age, we can really individualize what indicators might look like and use that as a way to infer whether or not somebody is possibly assenting or withdrawing assent. And here's just an example, some of the research that I will soon be going over with you. I really liked this article. This is by Digotardi et al. In 2018. And what these researchers were doing, they were working with infants. And so their participants were 7 months to 24 months years old. And they were looking at the quantity of audible and clear teacher language that the children could hear from different points in their classroom or their nursery. And so for this project, what the infants had to do is wear a little vest that had a little tape recorder in it. And they were able to record how much that child could hear and how clearly that information was getting to them. And so to collect assent for this study, these authors said that if the child is refusing to put on the vest, or if they're upset, they don't want to be wearing it, that infant is not choosing to participate today. So they described a couple examples where it would be after nap time, the kids would wake up, there was one student who was crying and didn't want to wear the vest, and they said, okay, this individual doesn't want to participate today. And then lastly, an IRB or a parent might waive the need for assent. So parents might waive assent for a necessary medical treatment. So that might be for a vaccine, it might be for treatment for childhood cancer. This is a time where parents say, you just have to do this thing. You don't really have a way to get out of it. And similarly, an IRB might deem assent is not necessary due to either the nature of the research or because the participant lacks the capacity to provide meaningful assent. Okay, so what I'd like to do before we move on to kind of part 2, are there any questions or reflections on kind of the basics of Assent? Anything anybody wants to jump in and ask or say before we move forward? Okay, Michelle will continue to monitor the chat, but I'm excited to move forward. So we've covered kind of the basics of Assent. And as mentioned earlier, Assent is a little bit of a hot topic right now. We're talking about it a lot in applied behavior analysis. People have been talking about Assent for quite a long time in pediatric medicine. It's been talked about in education. So this is not a new conversation, but it does seem to be kind of a conversation that is on the forefront right now. But it's largely ambiguous on how researchers are seeking Assent, how they're doing it, and also like how should it be done? What are the best practices? And so our research team is investigating some of these empirical questions. And what I'm going to share with you for the remainder of our time together is one of our current projects. And this research is going to be shared at the upcoming ABAI conference in May. But we looked at the extent to which Assent methodology is reported in published early childhood research. And we also did a comparison of Assent methodology within early childhood and behavior analytic research. So this project is formally called a review and comparison of Assent methodology in early childhood research. There is no debate on the importance of protecting participants of vulnerable populations in research. And vulnerable populations in research include some people of determination, but also children and adolescents. One way that researchers can protect individuals in research is to seek assent from those who cannot legally consent. So as mentioned earlier, consent is a formal agreement with which there are legal implications, and it must be collected prior to research participation. Assent, by contrast, is a proxy to consent, and generally an affirmative response is going to be taken as a willingness on whether or not that child is choosing to participate. Although assent is not always required by law, many a times it is, and there might be regulations that do deem it necessary. So assent is really a way that we can empower those who cannot consent legally with a voice in their research participation. And so said differently, assent is a way for us to ask a child, do you want to be participating in this activity? Or asking an individual who is nonverbal, do you want to be doing this?
Sorry, Dr. Shannon.
Yes.
There is one question from the audience, if that's okay. And the question is, are there basically any consequences for not obtaining assent from a child?
So I think it kind of is going to be dependent on the context. So I think if you are in an organization or an entity, or there are local regulations that require it, and we're not doing it, that could be problematic. I think there are oftentimes a lot of clauses or a lot of kind of wiggle room in that. What is most common is that we'll say assent might be necessary, or if, assent could be waived if the individual doesn't have the capacity. And it's, we're going to talk a little bit about how does a really young child have the capacity? How does an infant that's 12 months old have the capacity to say, I choose to participate in this research project where I have to wear the vest? And so a lot of times there is opportunities for that formal requirement to be waived. So I think oftentimes there are not major implications if you have that kind of protection. I think one thing to think about from a child's perspective is, if we're not seeking assent, what are we teaching children? And sometimes what we might be teaching them is that they don't get a say-so. Adults may not listen, that maybe adults in charge are sometimes crummy people to hang out with. So I think there are some kind of indirect consequences that could happen. It doesn't mean that they do, it doesn't mean that they will, but they're possibilities. I hope that answers a little bit of your question. Okay. Any others from the chat to answer before we move forward?
Yeah, there was kind of a follow-up from Diana about law and how the law protects children. I think you've kind of touched on that, but if you have anything further to say about the legalities of assent.
Excellent. Yeah, and I think that what is tough is there are not global requirements that deem you absolutely have to do it this way or you absolutely need to not do it the other way. A lot of it is going to be there are international guidelines. A lot of it is going to be regulated by kind of local law or even the entities that you're working with. But there's a lot of guidance, but I don't think that there are a ton of like firm hard rules on assent that would be applicable on a global scale at this point. Okay, please keep your questions coming. So seeking consent is relatively a straightforward process. And seeking consent is going to involve a researcher providing an explanation of the study, giving a description of the risks and benefits to the potential participant, and a description of the procedures of what that person can expect. And this potential participant will reflect on that information and determine whether or not they're going to participate. Seeking assent, by contrast, is a little bit more ambiguous, and because of this, seeking it can become a little bit more challenging. So using that example, if you are conducting research with a typically developing 7-year-old, a child who has vocal language, has good comprehension skills, this process might be fairly easy, and it also might be effective for that individual. So as a researcher, you explain the project to the child in a way that they can understand. The child can comprehend what the researcher is telling them. They can think about it and they can say, yes, I think this is a project that I would like to participate in. But what does that process look like for a 2-year-old? A 2-year-old has some language. They might have a vocabulary of around 50 words. A 2-year-old is mostly using yes and no reliably, but not always. And then what does that look like for an infant? Early childhood is a developmental period from birth through age 8, and this period is considered critical in development, with rapid learning happening across multiple domains. And there are several challenges to seeking assent with early childhood participants. There are those challenges of language development. There are those challenges of comprehension. But there's also challenges that children may not have the ability to think ahead or plan ahead, think forward. Children may not acquire that skill until they're about 4 or 5 years of age. And so what this means is that if a child says, yes, I agree to participate today, they may not be thinking about their participation tomorrow or a week from now or a month from now. So that's something we need to take into consideration. It's also important to take into consideration the power dynamics between adults and children. Children oftentimes will do the things that adults ask them to do because they've been taught to listen to grown-ups. So simply asking, do you want to participate in this project, might be perceived more as a demand than it is even a question. So Morris and colleagues recently conducted a review on reported assent methodology in applied behavior and analytic research. And as known to all of us in this chat, or most of us on this webinar, behavior analytic research is commonly conducted with individuals diagnosed with autism spectrum disorder and developmental disabilities. And so seeking assent can pose some of the same challenges as those just described. And these authors were specifically interested into investigating how often are assent procedures reported in behavior analytic research? When assent is reported, what are the details that are being provided? And what strategies can be identified for collecting assent from people of determination, and specifically, what strategies can be used for individuals diagnosed with autism or developmental disabilities. And so those authors reviewed 16 behavior analytic journals to identify experimental research articles that also reported on assent methodology. They found that out of 23,447 published articles, that there were 187 that reported on assent methodology to any degree. In most cases, no details of assent procedures were provided. Occasionally, there was minimal detail provided, and seldomly were there detailed procedures. So the focus of this current review was to look into the scope of methods used to seek assent with early childhood participants. We were interested in replicating and extending those review procedures used by Morris and colleagues and apply that to early childhood development research. For the purpose of this presentation, we were also interested in comparing and contrasting the findings of early childhood and behavior analytic research. So we had 19 peer-reviewed journals that we included in our review, and these journals were identified using different university library guides, consulting a list that was provided by the local authority on early childhood. And we had 2 experts in early childhood review our list, provide recommendations, and help make sure that our journal list was fully vetted. We searched those journals first over a 40-year period to determine the total number of articles that were published. And our time period was from January 1983 to March 2023, so 40 years and a couple months. Then we searched these journals for articles that included assent anywhere at all in the text. We were looking to include research that had been published in a peer-reviewed journal, so that was one of the criteria for our journal list. The research needed to be conducted with early childhood participants, and the authors also reported on the assent procedures used. Early childhood participants were participants ages birth through 8 years and 11 months, or infant through grade 3. Our exclusion criteria was that all participants were above the age of 9. The article was a review or a discussion paper. The word assent was not related to the experimental component of the study, or the article was inaccessible or not reported in English. And only 2 articles were inaccessible or not in English. So similar to Morris and colleagues, articles were categorized on the extent to which the assent methodology was described. So if these were categorized as waived, the assent was not required for at least some participants. No detail, assent was obtained, but no further information was provided. Minimal detail, there was written or verbal assent was obtained, but the authors didn't provide further details about the assent processes. And detailed, there was specific information describing components of obtaining assent. Detailed procedures were further coded by the strategies employed by the authors, and these were also similar to Morris and colleagues. So was there a written pictorial or verbal description provided? Did they describe the content of the question the researcher used to obtain assent? Did they require observations of assent or dissent? And a couple others on the screen. As an extension to Morris, we collected information on the frequency of assent procedures, or it might be better to say when assent was collected. Oh, sorry, I'm reading my future slide to you. We collected information on who obtained assent from child participants. So was this the parent or caregiver? Was it the researcher or research assistant? Was it the teacher? Was this information not reported, or was it something else? We collected information on the frequency or when assent was collected. So these were coded as it was collected once at the start of the study. It was collected continuously at predetermined intervals. This information was not reported, or others. Also, as an extension to Morris, we collected information on the rationale for waived assent. So if an article was categorized as waived, we coded if any rationale was provided. Was it due to the participant's age? Was it due to verbal skills, intellectual capacity? And lastly, we were interested in collecting information on, for those waived categories, who made that decision. Was it the IRB or ethics board? Was it a parent or caregiver? Was it a research assistant? Was it not reported or other? Here are the 19 journals that we included in our review. All of those 19 journals were reviewed for articles that collected assent with early childhood participants over the last 40 years. 39,043 articles were published from January 1983 to March 2023. There were 2,104 articles identified that included assent anywhere at all in the text. 946 of those articles were excluded, leaving 1,158 articles that met criteria for the current review. The assent methodology data that I'm going to share with you over the next several slides represents assent procedures used with approximately 138,500 early childhood participants. And this is an estimate on the lower end because some of the articles that we reviewed did not report the total number of research participants they had. And it also might have been the case that they did not report on the specific number of early childhood participants. So for example, a study may have had 100 participants between the ages of 5 to 15. If they didn't specify the number of participants that were within our 5 age range, that data is not going to be captured in this 138,000 here. But regardless, this data represents assent procedures used with at least 138,000 participants. We broke down the ages into different categories. So we have 0 to 11 months, 1 to 2 years and 11 months, 3 to 4 years and 11 months, and so forth. And that information is depicted on the top row. The second row provides the total number of articles that included participants within that age range. A study could have included participants from different age ranges. And if that was the case, they would be coded under all categories that applied. And the third row provides a proportion of articles out of the total number of articles included in the review. And as you can see, children between the ages of 5 to 8 years and 11 months are the most common early childhood participants for which we have assent methodology reported. Here are the data for categories of assent. Less than 3% of articles were categorized as waived. 40% of the time, there is no detail provided. 31% of the time, there is minimal detail provided. And 27% of the time, procedures are detailed. Out of the 315 articles that were categorized as providing detailed procedures, 63% provided a written, pictorial, or verbal description, and 44% described content of the question. Rarely did researchers have the participant experience the procedures prior to the research project. When it comes to who seeks assent, this information is typically not reported, and that was 80% of the time. And based on the data in the current review, almost 50% of the time, researchers are not reporting when they are seeking assent, but about 31% of the time, if they are collecting it, it's being collected at the start of the study. There were only 32 articles categorized as waiving assent. And of those articles, here's the data for the rationale provided as to why assent was waived. And it was almost always due to the participant's age. It is important to note that that might be the case that assent is waived in a lot more studies, but that information is just not ending up in published manuscripts, which would make sense because assent was waived, so that information may not be relevant to the write-up. And then lastly, when assent is reported to be waived, 81% of the time it is not reported as to who makes that decision, but there were 3 articles identified in which it was the IRB or the ethics board. So our first objective for conducting the current review was to understand the scope of methods used to obtain assent. And out of close to 40,000 research articles, assent methodology was reported only 3% of the time in early childhood research. We used those procedures described by Morris and colleagues and extended it to early childhood research. And this data suggests that most of the time, details on assent methodology are not reported. When details are provided, like we mentioned, written, pictorial, or verbal description is most common, as well as the authors giving us a little bit of an idea of the content that was used to ask about assent. And as an extension to Morris, we were interested in investigating who seeks assent and also when or how often assent is being collected. And the majority of the time, this information is vague or it's not being reported in manuscripts. When it comes to comparing and contrasting assent methodology between early childhood and behavior analytic research, on the left of this slide, I think that's on your left, is the slide of a pie chart indicating the extent to which assent methodology was reported in behavior analytic research. And on the right is the same depiction in early childhood. As mentioned, we have only about 3% of the time in early childhood research are assent assent methodology being reported. And this is quite similar to the findings of Morris and colleagues who reported less than 1% of behavior analytic research, including details of assent methodology. This finding is interesting because the results are almost identical across two fields, both which conduct research with vulnerable populations. These findings are concerning because it shows that we don't know a whole lot about the assent methodology that is being used in research contexts. And how much detail is provided when assent is reported on? For both behavior analytic and early childhood research, most of the time no details are being provided. And so it's kind of like we're saying, we collected it, we did collect assent, we're just not going to tell you exactly how. And across both fields, waived assent is almost never reported. Although no details are provided, still the majority of the time in early childhood research, we know they're doing it, we just don't know the details. There does seem to be slightly more details are reported in early childhood research compared to behavior analytic, especially when it comes to providing at least minimal details, which is again about 31% of the time. So in summary, there was agreement on the importance of seeking assent. This is evident in behavior analysis, it's evident in early childhood. This conversation has been long discussed in pediatric medicine and even recently in mainstream media. There's a lot being reported on sharenting, which is parents sharing pictures of their children online. So assent is important. Lots of different people are talking about it. But descriptions of assent methodology are seemingly absent from published literature. Simply talking about assent and advocating for its use are possibly not enough to ensure that researchers are doing it well. Our science really would benefit from more empirical evaluations on assent methodology. So some questions for us to investigate. What's the efficacy of specific assent procedures? Comparison of assent procedures. Is option A better than option B? How do researchers decide what procedures to use? When we have efficacious options, how do we teach researchers how to select and what are the conditions under which they choose A versus B? How often assent should be sought is a question that I think is really valuable and important to really understand. And this is just hot off the press, but Morris and colleagues just in the last couple weeks published an article, and they recently proposed 6 considerations for assent, and really for assessing and embedding assent into practice. And so some of the things that these authors are advocating for are assessing skills related to assent, teaching skills related to assent, and also informally assessing assent. It certainly seems that researchers want more and better information about assent procedures. Mead and colleagues just recently conducted a survey of behavior analytic researchers, and they were interested in learning about what their understanding was of consent and assent practices. And what they found was that behavior analytic researchers really report that they would like more empirically validated procedures. They want better details to be published in manuscripts so that those procedures can be replicated. And they would also like better training on assent methodology. And these sentiments are also shared by Conroy and Harcourt, who have long argued for assent processes to be better understood and reported in early childhood, as well as by Jaffe and colleagues who are advocating for more details to be included on assent in international guidelines for including children in clinical trials. In conclusion, empowering our most vulnerable research participants, those who cannot easily communicate, is critical. We owe it to those that we are working with and doing research with to identify the most effective and meaningful ways for seeking assent. Let's not just do it, let's do it well. And when we can answer these questions empirically, we can best inform practice and feel confident that the ways in which we are seeking assent are effective and meaningful. Our research participants, our clients, the children around the globe deserve it. I thank you for joining me to talk about a topic that I'm just passionate and excited about. Please feel free, if you have a question that did not get answered, or if I gave an answer that you're like, I need something more, please do not hesitate to reach out. And our last...
I didn't want to cut you off, Shannon. Thank you so much. That was absolutely wonderful. Thank you so much. As you can see in the chat, it's going to get lost now because everyone's telling you how wonderful you were, Shannon. There are 2 links for everyone for the BACB certificates in the audience. So that is BCBA-Ds, BCBAs, and BCABAs. If you can please make sure you fill out the evaluation form that I've put in the chat, and also there's the link to the CEUs. So thank you so much. I agree with everyone that it's such an important topic. So lots of words of thanks and praise coming to you. So thank you so much, Shannon. We are going to move to our next webinar, but there was one question that I thought if we can just take 1 minute from the next webinar to address, because I thought it was an interesting point by Gregory, and he was talking about what role does consent have in the process of obtaining assent from a person? If you want to maybe speak to that for a minute. Thanks, Shannon.
Yeah, no, it's an excellent question, and consent has to come first. In almost all cases, a caregiver, a parent, has to give consent before assent comes on the table. I think what makes it challenging is when parents consent to something and maybe the child is not assenting. Those are some points for question. And I think it kind of comes down, or what are the conditions under which, if we're talking about a vaccine or a life-saving medical treatment, whether or not that child assents to that activity, their assent may be overridden by their parents' consent. Things that when we can't take the child's assent as the final answer, ways that we can what we can do to work around it, and this is a recommendation in pediatric medicine, is we can still allow that child to have a choice. So we might say, I'm sorry, you've got to get this vaccine. It is going to hurt for a moment. Do you want to do it right now, or do you want to do it in 5 minutes? Do you want to watch me do it, or do you want to close your eyes? Would you like to play on the iPad and listen to headphones? But right now, consent overrides assent, but there are certainly questions that come up that don't have firm answers.
Thank you so much. Thanks a million for that, Dr. Shannon. Okay, I'm going to stop the recording now. Thank you so much.